So Ars is a medical doctor and a PhD candidate, and her research focuses on axial breath analysis in ILD with a special interest in pulmonary fibrosis and sarcoidosis. The objective of her research is to validate eNose technology for its application as point-of-care diagnostic tools in clinical practice.
Thank you very much for the kind introduction. I think I don't need to tell much more about myself, so I'd like to continue telling you about the most recent results of our research being done in Erasmus University Medical Center in Rotterdam, the Netherlands, together with my supervisors, Marlies Wijsenbeek and Catharina Moore. First of all, my conflicts of interest. And I will show you a short outline of what I'm going to talk you through. I will first give you some background about interstitial lung disease, also some more information about electronic nose technology, our results in ILD over the past few years, and some future perspectives. So interstitial lung disease, for the people who are not familiar with this group of disease, I will give a short introduction. It's a large group of disease that encompasses over 200 diagnoses, of which most are rare diseases. And here you see how they can be categorized. So they're chronic, they're subacute and acute forms of ILD, and the etiology is varying among the diseases. Also, the pulmonary abnormalities that are visible in chest CT scan vary between the diagnosis, and patients have fibrotic and or inflammatory abnormalities on their chest CT scan. The treatment also varies between groups, which some patients benefit from immunosuppressive drugs, and other patients benefit more from anti-fibrotic agents. But it's very difficult to determine what patient benefits most from what treatment. And last but not least, also the disease course is very unpredictable. So both within the diagnosis groups, but also between the diagnosis groups, there are many differences between patients in terms of disease course, progression, mortality rates, etc. And that's actually depicted here. So you can see some patients have a mild form that is reversible after treatment. Some patients stay stable their whole life. Some progress slowly and some very fast. But in most patients, it's going up and down throughout the years. And it's very difficult to predict where it will lead them in the end. But one step back to the diagnostic journey that patients go through before they receive a diagnosis. There's a lot of delay in the patient journey, as you can see here. So both patient, GP, hospital, and in specialized centers, patients need to wait. They undergo investigations, they get treatment, which might be not the correct ones, because it's quite difficult to set the diagnosis. At a CT scan, you can visualize the pulmonary abnormalities, as you can see here, but it's not the only thing we need for ILD diagnosis. To know in what specific ILD category the patient fall, we need a lot of different investigations. We need lung function, we need blood samples, we need sometimes an invasive biopsy, and we discuss this in a multidisciplinary team, and we come to a consensus diagnosis. There's always some uncertainty, but we try to limit that as much as possible, of course. So having said that, there are quite some clinical needs in interstitial lung disease in terms of disease screening that should be improved, diagnostic that should go faster. We want to predict the disease course better and also the treatment response. So let's go back to the breath analysis. Of course, we are all aware with the volatile organic compounds in breath, and we heard a lot of different analysis techniques over the day. But I will focus mainly on electronic nose technology. And here you see a very, very easy diagram on the comparison of those two techniques. And I think they have some similarities and differences, but the eNose focuses mainly and only on the VOC profile. What is the advantage of eNose technology? In general, it's a quick procedure with real-time results, which makes it very suitable for use in clinical practice, and it detects a wide spectrum of VOCs. The disadvantage of detecting a wide VOC spectrum and not identifying the individual compounds is that there we need a lot of data. And next to that, there are many different eNose devices, and they all have different sensors or work slightly different, so data is not compatible between devices. Here you see an overview of a couple of eNose devices that are currently used in clinical research and that have been studied for respiratory diseases. It's just to show you the differences between the devices, the sensing material, for example, the area composition, but also how they collect breath and how they instruct the patients. If you want to know more about this, you can visit the website or look up the publications of these devices. So the electronic nose we use for research is a SpiroNose, which is manufactured in Leiden, here in the Netherlands, and is a technically validated and certified device. It's a real-time analysis tool. It's cloud connected, so it sends the device instantly and can provide results instantly. It contains 7 metal oxide sensor types in various arrays, and the arrays are present on the inside and the outside of the device, so it enables the correction for ambient air. Here you see what the sensors sense and what the range is of the sensors. So the data output and processing, I will introduce you to. What you can see in the first picture are the lines that appear on the screen during the eNose measurement. So when the patient is performing the measurement, we as investigators immediately get to check the quality of the breath maneuver. We are trained, and as you can see here, there are bumps for every exhalation of the patient. And we are instructed how it should look like to be sure it's a good quality measurement. All the data that comes out of that is pre-processed, and in the end, it will lead to 7 peak sensor values and 7 sensor values, breath hold value ratios. We use mainly PLSDA to process the data, and we use it for larger cohorts. We use a training and a validation cohort. So these methods we have applied to several patient groups in our hospital and in other hospitals in the Netherlands, and I will give an overview of our recent results. We have results that support the disease screening of ILD, diagnostics of ILD, and the treatment response prediction of ILD. So first, the diagnostics. When we started using this device for research and wanted to know whether ILD could be detected by an eNose, we asked a cohort of ILD patients and healthy controls to blow into the nose, and we found very great results, and that was actually the basis of our research line here. We also asked sarcoidosis patients, which is a very heterogeneous disease and can present with ILD abnormalities in the lungs. And when we compared a group of 250 patients with 50 controls, we found area under the curve of 1.0. And when we compared all patients with pulmonary abnormalities with patients with other ILD diagnosis, we also found good accuracy of 0.8. But of course, it's much more interesting to know whether we can separate individual diagnosis, as usually it's quite clear whether a patient has a certain type or has ILD in general or is healthy, but not what type of ILD. The study was not powered for this, but post-hoc analysis showed us that, for example, IPF, idiopathic pulmonary fibrosis, could be separated from non-IPF patients. And we're currently conducting a prospective study to investigate this further, because that would enable application of this device in the hospital. Here you can find the study protocol if you're interested in that. And what about other lung diseases? If we ever want to use this device in clinical practice for disease screening, we have to know whether ILD can be distinguished from other lung diseases. So we compared a cohort of ILD with other respiratory diseases like asthma, COPD, and lung cancer, and found in both the training and the test cohort a very high area under the curve. And also when we compare patients with a disease that have similar etiology, for example, smoking-related diseases like IPF, COPD, and lung cancer, we also found quite adequate separation of these groups. Another disease which is in high need of a good screening test is systemic sclerosis. This is a autoimmune connective tissue disease, and it can present with abnormalities in the lungs, which is the main cause of mortality in this group. So we compared patients with systemic sclerosis with ILD and without ILD. And we found that they have a particular breath print, which is very interesting for future research. But also patients with systemic sclerosis-related ILD and other connective tissue disease-related ILD could also be separated. If we then look at treatment response, we did a very small pilot study in patients that were starting to use nintedanib. Nintedanib is an antifibrotic drug that can be used in patients with progressive pulmonary fibrosis, which is a deadly phenotype of ILD. But not all patients respond very well. So the goal is to stabilize the fibrosis formation and therefore stabilize the pulmonary function. In this case, we took the FVC as a measure of pulmonary function and looked from baseline to 3 months after start of treatment, whether they stabilized or improved or declined. The eNose was taken before they started on therapy to see whether we could predict treatment response. And although it's a very small group, these first results are very promising. Also, prednisone is prescribed quite often for more inflammatory-based ILDs. And here you see a separation of the patients who did improve or did not improve on prednisone, with also an area under the curve of 0.976. So in short, that's what we have been conducted over the years, and what are we working towards and how will we get there? Because of course, this technology is promising for clinical practice, but we need a lot of more data. We need more validation studies, first of all, to validate the results I just showed you. We need patients and healthcare centers, not only as what we did studies right now, but we need more primary care centers, we need more secondary care centers, and also international cohorts to see whether the results can be validated. And for screening purposes, of course, we need patients that are suspected or have early stage of respiratory disease. And that will hopefully lead us to a point of care medical test that can identify patients that are suspected of ILD, or maybe give more confidence to the multidisciplinary team to set a diagnosis. We hope that it enables earlier referral, quick diagnostic trajectory without delay for the patient, and accurate treatment. So I hope this was an interesting new topic for you to hear about today, and I'm happy to answer any of your questions.
Brilliant. Thank you so much for that, Irish. Really appreciate the time. So yeah, as a quick reminder to everyone, you can post questions down in the Q&A function at the bottom. So I had a couple of quick questions to kick us off. Obviously with eNose, you don't necessarily know what the VOCs are, but I'm wondering for these types of applications, if you have a sense of what the underlying VOCs and biology may be that's kind of driving the performance of some of these models.
Yeah, that's a very interesting question. I think also very important to know. What we sense right now is that inflammatory processes are driving most of the breath profiles of our patients. We also see quite a separation between patients who are more inflammatory have a more inflammatory phenotype and who are more fibrotic. And we're actually currently conducting a study with GCMS to also see whether that's actually true and if we can find specific FOX that discriminate those two groups. Because inflammatory cells are most active in the lungs and also produce most VOX. And for fibrotic patients, that seems to be more stable.
Brilliant, thank you. Do subjects need to fast before the measurement? It's one of the questions that's come in.
No, they don't need to. We collect all the data about their recent food intake and medication intake, also how dyspneas or how much they cough at the moment. So we can do post-hoc analysis. But so far in our cohort, we did not find any significant influence of food intake prior to the measurement.
Brilliant, thank you. One question just relating to the performance. So I noticed there's the 6 metal oxide sensors that are in the device, and it looked like the concentration ranges that they could detect that tended to be at the ppm level. Do you think that's sufficient, given there's a lot of volatiles down at the ppb and even the ppt level?
Yeah, I think because we work with sensors with different sensitivities, it will never be possible to get all the volatiles there, but that we have the most important ones, or at least for ILD, because it's very clear that the sensors respond to the VOCs that ILD patient exhale. We see also different diagnostic performance when other types of eNose are used. So I think there's still some research to do there to see what eNose or what sensors are best for what disease type.
Yeah, no, it'd be interesting. It's, you know, a lot of what we've observed are very, very low levels. So it'd be interesting to see what is translatable. Another question, is there any long COVID related lung disease? Is that of interest given the inflammatory related pathophysiology?
Yeah, that is of very much interest. I think a group of researchers in Leiden have recently published some results of patients with post-COVID and long COVID syndrome. And they found that there are differences in the breath print of those patients. What we found here in clinical practice, but we did not measure them with eNose, is that they have, if they develop fibrosis from COVID, it's usually a type that is reversible. So that when patients get treated or just recover without treatment after COVID, that the fibrosis itself does not last in the lungs. So therefore, we did not investigate those patients in our cohort because it's a bit outside of our aim. But there's definitely literature on that. Yeah. Okay,
great. Next question is, how many eNoses did you use in the studies? Was training done on multiple devices?
Yeah, depend. Like if we conducted a multi-center study, of course, we use multiple devices, but they're all manufactured in the same factory and also validated. And we perform a validation measurement every month. So we are able to correct for some minor discrepancies in sensors between the centers. Yeah.
Great. And then last question, you mentioned that there's future validation studies. So presumably they're going to be blinded studies. So you won't know what the label is and you'll provide the classification for the subjects. Is that the idea?
Yeah, definitely. Yeah. So until now, we mostly did supervised analysis. So indeed, the algorithm knew what the diagnosis of the patients was. But yeah, the perfect test will be to ask to the software, what do you think this patient has a diagnosis, and then go to the multidisciplinary team to establish a clinical diagnosis and see whether it's similar or not. Because a gold standard to validate we do not have, unfortunately. So that's essential.
Yep. And one last question, actually, would correlation to blood, urine, or imaging tests help diagnosis of ILDs?
Correlation of the eNose results, you mean?
I assume that's what the question is. So blood, urine, imaging along with the eNose.
Yeah, I think in the end it will definitely be an integration in clinical practice. So the electronic nose will not be the only device that will give the physician a diagnosis and that's it, because there's no current gold standard. So we train the device based on quite some insecurities. However, I think when we take it into the MDT together with all the other results we have, I think it's a very good addition. Maybe we find also relationships with the amount of inflammatory changes or fibrotic changes.
Excellent. Thank you so much, Iris. I look forward to seeing the future validation studies. I'll be curious to see how that result looks. Thanks again for the time today. I really appreciate it.
Thank you for the invitation. Have a great conference.
Thank you.